good to have you back. We're going to recap a little bit first about what we've learned so far about diabetes, and then we're going to finish up this series with just a few more slides and kind of identify a little more detail about some of the complications associated with it. So we have learned all about the pathophysiology of diabetes. We've looked at how insulin is made in the body. We've looked at how glucagon is made and the relationship between those two. We have studied the difference between type 1 and type 2 diabetes. We have looked at the different treatments for type 1, the different treatments for type 2. In detail, we have studied the difference between hypoglycemia, which is low blood sugar, and hyperglycemia, which is high blood sugar. And we have reviewed and gone into detail about the complications that can arise as a result of diabetes. So that being said, we are going to talk a little bit more about some of the complications before we finish up this series. So, I have already kind of talked about this, but now I want you to kind of look at it in a little bit of a different light. So we've talked about things like retinopathy, right, which can cause blindness in the diabetic. And we've talked about things like the type of vascular disease that can cause you to have poor wound healing, okay? And so those are kind of two different types of vasculature that we're dealing with. So one of the things I want to highlight in this part of the lecture are the macrovascular complications and the microvascular complications, okay? So when we talk about macrovascular, we're talking about large blood vessels like arteries and veins. And when we talk about atherosclerosis, right, we mentioned before that this was plaque forming on the wall of one of these large arteries or veins. And so that is a macrovascular complication of diabetes. And we're talking about larger vessels such as the blood vessels in our leg. So here in this example, we see that peripheral vascular disease, or PVD, results in poor blood flow through the larger arteries of the leg, all right? And so we also know that this type of poor perfusion, right, can lead to not only poor wound healing, but actual amputation, which is when they have to surgically remove a limb due to after time goes by and the circulation is not good. What do we know that happens to the tissues when they are not supplied with blood, the nutrients, the oxygen, and waste products are removed? What do we know happens? We know that cell death occurs, right? When tissue death occurs, we end up with necrosis or sometimes gangrene in the feet. And it can start in just the amputation of a foot, and then over time it gets to be a below the knee amputation or even above the knee amputation. Here we have an example of a below the knee amputation. And this is a result of vascular disease, a macrovascular complication of diabetes. However, there are also microvascular complications that we have talked about. We define the microvascular complications by being involved with small blood vessels such as capillaries. Capillaries are where nutrients and wastes are exchanged. And so here we see an example of a vein. We know that that carries venous blood, blood that has already been used up by the body. And then we can see this new, fresh supply of blood coming from our artery. And this is the blood that is being carried out into the body to perfuse it, to provide oxygen and nutrients and exchange of waste. And this is kind of where that happens in the capillaries. That exchange takes place. So if we look at an example of a microvascular complication, we can see here, this is a nephron, this picture on the bottom of this like really interesting squiggly lines. But we can see, we're going to talk about what a nephron does in a later lecture, but what I want to focus on here is the nephron is the smallest functioning unit of the kidney, all right? So each, our kidneys have millions and millions of these tiny nephrons, and we can see here that there is very small capillaries that are at work in order to supply these nephrons with blood, okay? And so damage from high blood glucose can cause damage to these tiny blood vessels of the kidney, leading to kidney failure, okay? The glomerulus is the filtering unit of the kidney. We've kind of blown that up here. And we're actually looking at the blood vessels here that are allowing blood to go into the glomerulus and be filtered and come out of the glomerulus after filtering. And so actually what happens is if damage occurs to those particular teeny tiny blood vessels there, then our glomerulus, which is the actual filtering unit of the kidney, can no longer do its job, okay? And that's why one of the complications of diabetes is kidney failure, which then results in the need for hemodialysis, right? Where a machine now is doing the work that this glomerulus used to do. Okay, but the glomeruli, which is how you say it plural, are no longer functioning well enough due to damage to these little teeny vessels that you can see right here in the blow up of this picture, and that is where the failure is occurring. So I think it's really important to be able to look at the detailed reason behind some of the pathophysiology that occurs. Because some of the pathophysiology that we learn about some body systems help us understand other types of body systems and diseases as well. Because we have capillaries all over our body, okay? Every organ of our body is supplied, and the way the blood gets supplied is by these larger vessels, and they get tinier and tinier until we're doing this exchange at the level of the capillaries. One of the other things that happens in diabetes is diabetic neuropathy, and we talked about it before. But I want to again take it down to a more detailed level. So here we see a neuron. A neuron is the basic cell of the nervous system, and it's how our brain and muscles and organs communicate. So if our nerves are damaged, okay, we cannot feel pain. All right, and so we talked about in diabetic neuropathy, loss of sensation can lead to a small little blister on our foot that we don't notice, ending up being a large foot sore because we didn't feel the initial irritation of the blister, right? That's due to neuropathy. Well, if we get nerve damage that is throughout our body, it's very possible that we can not feel angina or chest pain. And so the other thing that can happen in diabetic neuropathy is that a diabetic could be having angina or chest pain and not feel that pain. And that could be very dangerous, right? Because what angina is it's a warning sign that we need to go get our heart checked out. And so if you're not feeling that, you could end up having a heart attack and never have known that you were starting to develop this chest pain. The other thing that can happen, there are many, many ways that this neuropathy can affect the body. But another thing that can happen is called gastroparesis. And what gastroparesis is when there is problems with our sphincters working, okay, and they are closed, okay? So our nerves kind of our different parts of our body. Like we said, you know, our nerves communicate with our organs for things to happen inside the body. And so what happens in gastroparesis is that there's nerve damage that affects the stomach and the intestines, okay? And when these sphincters aren't working properly, the food is not digested properly and does not move through the stomach and intestinal tract normally. This can result in a lot of backup, and the patient can feel nauseous and they can vomit. And what happens is because the transit time of the food is slowed by this nerve damage. This can also result in some pretty severe constipation. And so I just wanted you to kind of get an idea of how, you know, we don't necessarily think diabetes has anything to do with our GI tract, but indeed in some patients that have this problem, it does, okay? This is how a diabetic can have problems with constipation and slow transit time in their GI tract and nausea and vomiting, okay? And then also the ultimate example of this, which we've talked about a couple times now, is that numbness or that reduced ability to feel pain and even temperature changes in the body and in the lower extremity. Neuropathy can also cause actually a tingling or a burning sensation, which could be very uncomfortable as well. People will describe it as walking on pins and needles. But what I want to take a second to talk about is that poorly fitted shoes in the diabetic can cause skin breakdown that goes unnoticed. Now we all know that if we, any girls here in the group, wear a pair of tight-fitting, you know, stiletto heels or something that looks really great and rubs against our heel and can cause irritation, we feel that, and that's very uncomfortable. The diabetic may not feel that, right? And so here we can see on one side of the picture, we've got a little bit of irritation. On the other side of the picture, we can see how that irritation grows into a larger non-healing wound. And so I want to take a minute to talk about the importance of diabetic foot care. So nurses have a responsibility not only to teach patients about this, but to, in the inpatient setting, help them keep their feet clean. And so we want to teach them to wash their feet daily, to dry well, especially between their toes, because what happens is moisture between the toes can be a place for infection to take place, especially if there's some broken skin or even like a type of yeast to grow as well, right? And so we don't want that to happen. So we want to dry the toes, especially between them. We want to feel for bumps or temperature changes. If we touch the foot and it feels hot to the touch, it could be the indication of an infection. We want to look between the toes and check the toenails. We want to file the toenails straight across. And we want to check for dry or cracked skin. We always want to examine the bottom of the feet as well. And we always want to keep a record of what we're finding. The importance to keeping a record is so that we can know whether or not it's getting better or it's getting worse, okay? Other things to teach and to consider, or we mentioned before, wash the feet every day in water, but don't soak the feet. We don't want the feet to be moist. We want them to be dry and clean. after we dry the feet completely, we can apply some lotion to the tops and the bottoms of the feet. We try to avoid putting lotion in between the toes, which again could lead to a moist environment and infection. We want to encourage these folks to not go barefoot, to check that there aren't any pebbles or other objects inside their shoes. Always wear shoes and socks, even inside, to avoid injury. We want them to wear good fitting shoes, trim those toenails straight across and gently smooth any sharp edges with a nail file, but to nail file straight across as well. It's really important to have a foot doctor or podiatrist trim the toenails if the patient is unable to see or reach their own feet. So that's really important consideration as well. And not to remove any corns or calluses or use any over-the-counter products for that type of thing for people with diabetes and having those problems on their feet. So a lot of good teaching, a lot of important teaching. It can help prevent complications that can actually lead to the amputation, right, that we talked about a little bit ago. Because if they have good foot care, they're much less likely to get an infection that gets worse and worse and worse, and end up resulting in death of the bone, which is osteomyelitis, gangrene, tissue necrosis, and eventually amputation. Okay? And so small interventions can go a very long way. So I thank you for your attention on this topic area. I hope that you have learned something from it. Until next time, aloha.